I think we have people joining the Zoom.
Hide meeting.
Oh, nice. Okay.
It's just a more button and then hide meeting.
How do we get back when we need?
Just escape. So then you can move that way. Whoever you want to. And this, if this is awkward, you can
Make it bigger at all, or is it going to be hard to focus?
move back.
Pull it back.
Yeah.
Always worry about tiny text.
Oh, yeah, for sure. Off mic. Well.
This is-
Clear.
Is there like a button
This
for,
one.
that's the one for the, well, that's left, right? Is there like one for fuzziness or anything? Or? That's,
Might be as good as yet. Think.
that's pretty good. Oh, Alex, like I got new glasses.
In that stigmatism.
Oh, yeah, yeah.
Okay. Do you have any audio? That was the other thing.
No.
Okay, cool. All right.
That's cool.
Okay, guys, we're gonna go ahead and let Dr. Robert take over now. So please give your attention.
Okay, let's chat, everybody. Hi, I'm Eric. I think I've met most of you. I'm really bad at names, so I apologize. Exactly. So I got asked to talk about labs and Pacu, which is the most riveting topic ever to present. So we'll try to have fun, okay? Please stop me at any time if you have any questions about anything, or if you have fun stories to share, especially about residents who just screwed everything up. I love hearing those stories.
That never happened.
Because they just throw us junior people in here who know nothing, and then we're expected to do stuff. So that's always fun. My sister is a nurse, ICU nurse, and now is starting to become a CRNA. So I hear a little bit about the nursing side, but I always love hearing stories. And in general, I wish we did a better job of kind of cross-cultural understanding teaching, because they don't teach us anything about what a charge nurse is or about nursing stuff. We kind of have to just learn it by fumbling and pissing off nurses. So anytime you can kind of help us out with your experience, it's always great. Cool. So I always try to find jokes. I love jokes. But yeah, we don't always have the healthiest patients. We sometimes need labs because they're not always like your spry 21-year-old super healthy. So, and you find things in labs. When you look, you find things. So yeah. Sorry, I bike. Otherwise, I would have brought something. In general, we like doing the organ system approach, so I'll kind of stick with that. So we'll try to touch on a lot of the major organs here in our talk and the labs we would get for different issues. So we can start with people in love or maybe in chest pain. And so when people have chest pain, what labs do we order that you've seen that you think about? Tropes is the big one, right? When do you get tropes? And then you get cardiology being why did you order tropes yesterday? That was fun. And in general, I think the question is, what kind of chest pain is this? Is this acid reflux, or they bump their chest, or they're just kind of a hypochondriac, or do they have a Fleming MI that we need to deal with? If you have a lot of, so I guess the question about MI2 is with chest pain, is it from some kind of big clot that went into their coronaries and now it's occluded, and then we're going to see EKG changes and that crushing substernal chest pain? Was there some kind of existing inflammatory state, like they have really bad cancer, or they've been anticoagulated and they're off to anticoagulation, so we're more worried about the thrombus side of things? Or is it a thing where there was no actual clot, but the heart was either pumping crazy fast or was pushing against heart, high blood pressure, getting stressed out, not having enough oxygen, or there was low blood pressure at some point in the case, and then it's just an ischemic injury from not having enough oxygen. And that's where understanding what happened in the OR and the patient history is helpful to kind of figure out what bucket you might have for a heart attack. And there's a whole spectrum there. You can have like really bad heart attacks where the heart's like stops like functioning. You get hypokinetics on your echo, or you can have things where you just have like a little bit of mild chest discomfort that goes away, or maybe even some EKG changes where you like see a little bit of ST changes and it goes away. So like there's a whole spectrum there. But in general, yeah, like you have your classic MI symptoms. You probably know better than I do. I haven't seen a lot of MIs, unfortunately, but in general, yeah, like chest pressure, kind of tightness, radiation to left shoulder, to the jaw, that sort of stuff. And again, with the OR, like did the blood pressure go to like 250 for like an hour, or was it really low, maps like 40s for a while? Those would you'd be more worried about those kind of ischemic injuries that might not actually yield kind of the classic presentation from a clot. But other questions to ask the patients like, hey, is it pleuritic? Like when you take deep breaths, does it hurt more? And you're thinking, oh, maybe it's more like a PE. This chest pain is not necessarily cardiac related. Is it hurting when, like, and I push, does it hurt? And it's like, yes, well, maybe it's not as likely to be an MI. Maybe it's more like the musculoskeletal kind of anxiety, whatever. And again, like right-sided stuff, maybe it's more of the shoulder, like the surgeon wanted the arm, like doing something crazy, some ballet in the OR. And then other things with that, oh, like ask, like do you have a history of acid reflux, like that sort of thing. I mean, there's so many, chest pain is like a huge thing. But in general, the key things, yeah, like an EKG, to assess like how severe is the heart injury, if it is severe, and then troponins to check, is there like a mild injury that we don't see on EKG that we need to catch? And I think the big thing is like, how often do we draw it? I think it's changed over time based on the sensitivity. Our order set is now and in 2 hours from now, and we only use our order sets. We don't think in medicine, so that's what's going to get ordered by default, or should be ordered. Like yesterday's cardiology said, oh, you don't even need the first one, don't get the second one. So sometimes we're not going to actually draw that second one. And then different attendings have different preferences about do we need to have them here for both results, or do we just draw one, or can it all be done later, that sort of thing. But in general, we're probably going to draw at least one, maybe two, and maybe wait for the result while they're here. Yeah, but in general, you're going to want to get 2 troponins 2 hours apart. And there's like this whole algorithm that none of us actually can find, but is out there. And the big thing you'll see is just the 2 hour increment. And it's not necessarily just the level. You want to know how much it's changing by. So the number to remember is 6. 6 is an evil number with troponins. And the reason why this matters is because troponins are very sensitive, but they take time to build up. So over the course of hours, it'll continue to increase if there is a severe injury. And depending on the extent of the injury, you're going to have more cells releasing troponin, and it'll get to higher values. But there's a caveat here, which is a lot of people can have just high troponins at baseline. So if you have a history of like, especially like ESRD, CHF, certain conditions, your troponins are just always elevated too. You get your first one, and it looks crazy high, and you're like, oh crap, like their heart's just like dissolving in there with like bleach. And you get another one, it's just stable, and you're like, oh, I guess they just always have it high. So that first number doesn't necessarily mean much in of itself, depending on if they have a history of a lot of comorbidities or not. So that's why that delta, the change in the troponin really matters. And 6 is kind of the magic number where we start paying attention, but it doesn't necessarily mean we need to go to the cath lab and there's going to be this whole thing, but at least that's more of a rule-in thing. Yeah, I love your cardiac arrest. That isn't that fun? Yeah, I enjoy that one. Yeah, I mean, there's gonna be so many labs for that. You can imagine we're gonna skip that. But arrhythmias come up. We had some yesterday. Yeah, any badness on the telemetry? Like, what do y'all think about with that? What do we need to order? Yeah, electrolytes is a big one. Are there particular ones you think about? Potassium, calcium, any others? Mag's a big one. And the thing with and how do we get those? I guess what labs do we need to draw? Yeah, BNP is good. It takes a while to come back, right? So I feel like we tend to order the VBG because it's quicker, which is really nice. but someone might think to just grab a VBG and not realize if they're new or whatever, like there's no mag on it. So if we screw that up, just reminding us, hey, do you also want a mag? Like that's a nice prompting too if we're busy and didn't order it, and just to know that we'll probably want to draw VBG and a mag, and maybe also a basic for any of the arrhythmia stuff. Culturally, and from like the anesthesia time in the CVICU, everyone just gets mag. Like for any arrhythmia, it's just mag automatically. Like the more the better. Let's just pour it in there. So we might just start mag from the get-go while we're drawing labs. That's fine. And there's a lot of papers and studies on this that mag helps with most arrhythmias. There's a lot of stuff with AFib. But in general, that can really protect you from arrhythmias progressing. And it could abort it, but more about that progression. So for like kind of getting out of here, getting that mag started is nice. The tricky part is in the OR, we push mag in like 3 minutes and it's just in like 2 grams, boom, maybe like 10 minutes later, just another 3 minutes, boom. And then we push funnel or whatever if we need to kind of support pressure, and then you're good. So it's really nice when someone already loaded them with mag. It's just, and I know it's a huge pain to start it here, you have to go get it and set it up, and then it's 2-hour wait, right? And they're unpacking forever. That's something that like we're not always used to is, oh, mag takes a long time. So that's also something good to tell us as junior residents, like, hey, if you want to do mag, it's gonna take 2 hours. So like, even if we know they're gonna be here a while, or they're impatient or something, then it's you could prompt us like, hey, do you want to start the mag, this arrhythmia, these PCs? That's a good thing to bring up. Or if you're like, are you sure you want to do mag? They're outpatient, like they're going to be here a while. That's great for us to know because we don't think always about these logistical factors of where they're going and all that because we're so used to just in the OR. It's really easy to monitor, do stuff, and then someone else deals with where they go. So you all are really good experts about like navigating where they're going next and thinking about that bigger visions that we should be better at, but don't get a lot of great training on. So it's super helpful for you to tell us, hey, it need to be monitored for this long. It's going to take this long. Those are things we don't really understand. I think insulin's another one. Like, do we need to treat this insulin and then wait 2 hours to recheck it? Like that could slow things down. So again, in terms of numbers, when we check that mag level, we usually want it greater than 2. And usually it's like if the mag is like 1.7, 1.8, 2 grams might bump it to 2. So we automatically do 2. If it was less than 1.5, we might order 4. And in general, like we load people mag like crazy. They can go up to like mag of 4. I don't think we see that much, but that's why if you say, oh, the mag's like 3, it's like, whatever, let's give more mag. We're not going to worry about it so much. And like in OB, for preeclampsia, women are getting mag infusions of 2 to 4 grams an hour for like over a day. So 2 grams over 2 hours here is like, yeah. And again, and we're used to pushing it really fast. So then when we hear it's like, oh, it takes 2 hours, like, whoa. And even when we're pushing it fast, the blood pressure doesn't always change that much too. So we're always kind of, that's a good thing for us to know that we need to be taught. So every like 2 weeks when there's a new one of us, you're gonna have to like teach us, hey, mag takes a while. So I apologize, that's gonna be your battle. Yeah, any other questions about mag or cardiac stuff before we move on? Okay, let's go to lungs. This is always terrifying to see. So see someone having respiratory issues, whatever, they have interstitial lung disease, COPD, they're really obese, they're hypoventilating, they look like crap, whatever. Get RT involved, they take forever, they eventually put on CPAP or BiPAP. What are the labs around that we're thinking about, caring about, ordering? Yeah, blood gases. Yeah, we care a lot about the CO2. That's always the classic one, right? Is you have someone with really severe COPD, they go into the ED, someone just throws on a nasal cannula because they have a stat of 90, their stat's 100, and was like, great, they take a rest, they get CO2 narcosis because they have no drive to breathe, and then they have an arrest and die. Hopefully that's not too common, but CO2 is really big. Like we don't have a monitor for CO2, we just have oxygen. And CO2 levels are tricky because you're coming out of anesthesia, so you have lots of reasons to be sleepy. And maybe you're hyperventilating, so CO2 is going to be high. Like yesterday, Amy Young didn't even get a gas on someone. I'm coining it. Anyone? I'm the first person to say this. IBG, the IBG. Looking at the person and being like, that CO2 is going to be really high. We don't need to check it. Let's fix it. So sometimes you don't even need the lab if you just know it's going to be high. but maybe you're trending it. Maybe you check it, you do the beep, CPAP, BiPAP, whatever, check it again, just to make sure that it's actually working. But you can also use clinical judgment. Hey, they woke up more. It probably worked. So sometimes having the number is not always that useful. It's confirmatory, but clinical assessment judgment might be superior. But certainly if there's delayed emergence, they haven't talked to you at all yet, it'd probably be good to get a gas just to make sure the CO2 is not sky high. Do we need an ABG or can a VBG be enough? If we can draw off the IV or get a stick, is that okay if we don't have an A line? Sorry, what? Has to be. Well, I mean, I can just stick in the artery and suck it up. Yeah, I did it the other day. I can see why we don't do it. It was a mess. We have some EBL there. We have to update the chart. And it's painful, right? It's more uncomfortable. Yeah, all that. The VBG is probably enough. It's harder to interpret. The CO2 levels are going to be higher just by default. But if the CO2 level is like 80 on a VBG, that's just way too high. So to a certain degree, it can give you kind of a more qualitative sense of really high, maybe within the realm of normal. And then you might follow up with an ABG later if you're really needing the precise number for some reason. Yeah, VBG should be fine. So, and in terms of ABGs, I mean, in the computer, we have all the normal ranges. Yeah, I would say all the values on it kind of matter. We do it less for oxygen just because the pulse ox is so useful. Maybe if it's not reading, or if they have, I guess a big one is if they have like a VAD, so you're not actually getting pulsatile flow. Like you can't really use the pulse ox that accurately. So then ABGs, serial ABGs are how you're going to assess that. I think that's the main one when we use it for oxygen. I'm probably missing something there. Anyone has other ideas about when we do the ABG? Okay, but yeah, it really matters to consider, do they have chronic lung disease, COPD, when you interpret the gases? So here's an example. These are ABGs, yeah, ABGs. So normal people, or at least, yeah, pre-op or whatever, you have ABGs from a healthy normal person in the upper left and a chronic severe COPD in the upper right. They're going to have abnormal values at baseline. That's their normal. So their chronic CO2 retainer, they're compensating with higher bicarb, so their pH is normal. The pH will be normal-ish, but the bicarb CO2 will be abnormal. Then from these two people, you could then get the same gas afterwards, but the interpretation is totally different. So on the left, normal person, acidotic with pH of less than 7.4, higher CO2 than we'd expect. Their bicarb is still normal. So the bicarb being normal, that takes like hours to change, days to change. So their body's not compensating for some kind of lung thing. So the acid in their blood is from them not ventilating enough because they're obese or they have opioids on board. Well, less likely obese. So that gas would tell you, oh, we might need some Narcan. Does that make sense, or do we want to talk about that more? Okay, cool. So I'm sure you know all this. On the right, though, you have the exact same gas, but the interpretation is totally different. Their CO2 is normally high, and it's still high, but it's not like 80 or 90. So we're thinking, oh, that's probably not the contributing factor. But their bicarb is a little lower than maybe we would expect. Like, why is it looking more normal when it should be high at baseline? So because their bicarb is normal, that's abnormal to us. And then we're thinking, oh, there's something metabolic going on. We don't need to give Narcan for this. We need to treat their lactic acidosis. Let's give them fluids for their blood gas, for their what looks like it should be a lung thing, but it's actually a fluid thing because they're going into anaerobic metabolism. There's not enough delivery of oxygen or blood, both of those, to their body. They need more blood volume. So that's where, like, the same gas, you can get very different management pathways from. So that is going to be important. Yeah, I feel like this is like anesthesiologists, right? It's like everyone asleep. The sleep patient is the best patient, unfortunately. And then we give just so much clonidine to everyone asleep. But yeah, delayed emergence, right, is useful to talk about. This is not my kid. We're not recorded. I have my kids, but someone else's cute kid. We have like this whole delayed emergence algorithm that we get put into our learning materials or whatever. And in general, you do just the normal ABCs. You think about drug reversal stuff. But the labs we're going to want to get are there. So we want to get glucose. What values of glucose do you think are limits? I just flashed it, but what were you saying?
Less than 50 greater than 500.
Sure. Yeah, those would be good. I threw 50, 350, something, yeah, something really low or really high. That doesn't matter. 500 is fine. Just anything that's really abnormal, we might want to treat. But I mean, and if it were 75, I don't know, like you could consider it, but you want to check other things too. Yeah, if they're really acidotic, they might not be waking up because of that. There might be like CO2 narcosis going on there, or just in general, their blood's acid and the brain's not working great from it. So having a VBG or ABG would be good there. Sodium, really big changes in sodium, especially if they were normal to something very high or very low, but if they were, especially if they started abnormal for some reason and then went to normal, that could even be concerning. So there's change in sodium too. ICALs, being really low or really high, which should be on your gas. Yeah, sodium, no, that's okay. It's okay. We're a little tired this morning. That's fine. It's all good. It's all good.
That was good.
Thank you. Thank you. Yeah, when you have salt in your blood, it's not great in sugar, but or sugar in this case. Sugar. I need more coffee too. We can talk about the BDs. So what about like outpatient people? This comes up like, hey, this person's outpatient, their sugar is high. Do we need to do anything about it? Can we send them home? Like, how do you feel about that? When are you thinking like, damn, we need to give them insulin, or like we need to admit them for their sugar? Like how big are we talking here? Like 250,000? Like I think you ask 10 attendees to get 10 answers, right? Like, yes, us, we say something like there's no set thing.
That's why we're hesitant to answer, because it's like not.
There's the policy.
Yeah, we can talk about that. I'd at least like have a conversation for sugars above 300. And certainly like less than 70, we should be doing something, thinking about it. If they're normal and they're way above 300, you might want to treat it, or at least consider, hey, are they going to like HHS or DK or something? Like, just take a second thought. Yeah.
They've stopped it then abruptly and.
I took their sugar in 40 minutes, cut out, and they wanted to stop it, check it again in half an hour, and it went from 201 to 208.
I guess it depends, like if they're healthy, normal, and what's like a common medication we give that raises your glucose? Yeah, right. So if it's like decadron-induced hyperglycemia, they don't have a history of diabetes. There's no reason that they're having pancreatic issues.
That's what she told the doctor. She told me
Yeah. I mean, I guess there's also the issue of like, is this glucose going to cause an issue over the next 24 hours? Is this value, this vital sign, an issue, or is it something that needs to be managed over like weeks or months? A glucose below 200 is probably not going to be dangerous over the next few days until they can get to see their physician, get a prescription, get help financially, whatever it is. If it's like 500, that could be like dangerous. That starts changing the osmolarity of your blood. Like that's something to think about, or could suggest something else going on. Yeah, I guess the big thing here, which I had to learn, is if you give insulin, sub-Q in particular, like you got to wait a couple hours to check it. If you're coming off a drip, it's probably less than that because it doesn't last as long. Yeah, and then again, if it's low, we give amps a D50. Sometimes you have to give multiple amps. It's good just to probably check it. When would you recheck it after you gave a D50 amp? After the amp, and then say it looks good now. Like went from 70 to like 110. Are we happy? Do we need to recheck it again? When would you do that? Okay. I like that. Yeah, I mean, assuming they're not eating, maybe like, I think I read an hour. Is that what we do? Like an hour probably seems good. It's kind of a rough thing, but if they're eating, yeah, that's the trajectory matters, right? Like, are they eating now? And that's good to know. Like, we don't always see them and see that they're eating or could eat or whatever. So that's helpful information. Like, hey, yeah, they're probably going to eat. Like, yeah, you gotta lead us. You gotta make us think it was our decision, but it's totally yours. Just kind of lead the horse. Like, here's some oats. Like, they're going to go eat at home. It's fine. And yeah, the algorithm that we follow or that's posted is like, hey, any sugar over 70, they can go home, assuming they have some kind of plan when they go home with their oral meds or insulin they take. So technically, we don't, by this outpatient PACU algorithm, there's some cover to not do any insulin ever. So from that perspective, if everyone's comfortable with it, we probably don't need to treat insulins that are in the low 300s if they came in that way, or low, like mid 200s if they came in that way. But if they came in at like 100, now they're 350, that might be something we need to deal with. So I think that, I guess in general, if they're at their baseline, it's probably okay for many things, assuming their baseline is not dangerous. If they came in at 900 and they're still 900, probably wouldn't want to send them out. And then the inpatient side, there's the whole thing that we follow, but the big one, I think, is just type 1s. Like, they just need to have insulin. Did they have it last night? Something long acting, or this morning long acting? Were they on a drip? Make sure they continue the drip. Maybe we forgot to order the drip and it's going to get dropped. Like, that sort of thing's helpful just to make sure someone knows and confirms that they have insulin in their body at all times. Occasionally, for like a 2-hour procedure, we just don't give them insulin and we're like, it might be okay, we'll follow it. So like, we see that sometimes, like a really short case, but then we need to get the insulin on and not forget that. So that's something you can check and kind of help us out. Type 2, we check glucose pre-op, maybe intra-op. If it's a longer case, sometimes that gets dropped. We should check it post-op. If you're going to ICU, insulin drip is fine. L sliding scale. Sometimes we don't know, like, it's really hard for me to know if they're going mod care or ICU if it's an ICU location. So sometimes that's helpful to know, like, what's their level of care. But my understanding is if they are in an ICU location on mod care, they can't be on the drip. Is that right?
They can take insulin drips on the floor.
They can. I feel like I've always gotten pushback on that because it's too quick. You have to like monitor every hour, and it's Q4-hour checks, right?
It depends on what it is.
Oh, this is good. So these are things I don't know. So, okay. These are,
Like that every hospital.
okay.
Or step down with the patient.
There's a grid that lists like what these.
Yeah. So
Cool.
like our step down basically take it, but like
Most
or
floors.
like
Yeah, they figure.
okay.
These are the stuff we're just never going to figure out. So if you have
Yeah.
tips for us of what orders we should be putting in to get
So
this
we
thing
would
rolling,
tell
you should tell
like,
us.
if this patient needed an
Yeah.
insulin, level up their increase their level.
Cool.
That's something there's.
But there's a lot of floors, I think.
Yeah. Cool. Okay. Well, anyway, that sort of stuff's helpful for us to know, like what, and getting that started early if we need to start something or not or whatnot, or if we need to come off the insulin to monitor, like,
I think
help
what's
us out,
so
please.
frustrating sometimes, like here, is that if like this scenario Stan mentioned, like patient was in the OR, they're on a drip, and they come out, and we stop everything. Then it's like, now what? And
Mm,
so that's when it gets like how are we gonna treat this? Or are we just gonna wait and see, take another blood sugar in a half hour, and then
Yeah.
eat again, and then if they're stable, that's when it gets a little.
or is that mostly for inpatients or even outpatients? I thought there was an
I think
outpatient.
both. But there isn't like, and I don't know if this is referenced like from like the perioperative glucose management
Policy's that thing.
policy
Yeah, that everyone falls on.
that
all the time.
nobody uses.
Yeah.
because they started it hard. And so I didn't have the
Titration.
titration, it wasn't there.
Mm,
So then I had to find a teacher, which she helped me, but, yeah, so. that's
And
the
I
other
think,
thing.
so that's probably why a lot of times they just do abruptly stop it. Because then they don't have to put an order in for the whole
Right,
protocol, then they might give you like, additional, like, oh, we're gonna give like 4 more units or whatever, but, I don't know.
I mean, we have an order set and we can just kind of click drip or sub Q. It's like
Yeah.
3 clicks either way. So from our perspective, it's not harder. So if you feel strongly, you should kind of push us and just do it. Yeah, I guess.
And obviously it's patient specific, like,
Oh yeah, yeah.
to like how they're tolerating it, they're, if the brittle diabetic versus, like somebody who is just maybe
Yeah.
more or less like a one-off, but
I mean, I guess I feel because like sometimes people start the drip for like a glucose of like 200 and they have like well-controlled diabetes, not even on insulin. And it's like, do they really need that drip? And then we come off it and it's like, they don't need it. Like, that's fine. It was just kind of to cover them during the case. Versus they take like 150 units a day and they have like an A1C of 10 and it's like, oh man, like, and then I don't even know like how much should I give them subQ? That's scary. I just want to put on the drip. Someone else figures it out. Like,
yeah.
like I'm not like an internal medicine doc, like endocrinology. I don't know how to dose subQ insulin more than like 5 units for hyperkalemia. So like a lot of it's like at my our own experience level. Like we just don't do a lot of subQ insulin
Right.
in our training. But insulin drips where you all manage it is like totally easy for us. So or just not even think about it. If the sugar's 200, it's fine. Like we don't even need to do a sliding scale. Someone else will deal with it in 2 hours when they're gone. So I feel like anesthesia culturally is just not great always at that follow-up piece, particularly if they're not going to ICU, because we get mostly ICU training and OR training. Like that's where we come from. So you all probably have way more experience with seeing patients outside of those settings, and that could be a really helpful thing for us to know from your experience. So I think a lot of times the more humble of us will ask, hey, what would you do in this situation? What have you seen? Because like, I don't know. And you probably know more than I do. And it can be hard when you say, well, you're the doctor, or I can't give that opinion, which I get that. But it's like also, you do probably more experience than us and you're a healthcare professional. So it's helpful at least have a little like help sometimes or like a little point suggestion thing. Yeah. And like, and I get all the things around that. But yeah, we just help each other out. Like we all want what's best for the patient. And sometimes like we're having to make decisions, put in the order, and we don't know. Maybe our attending really doesn't know. They haven't done this in 30 years or whatever. So on OB, I think it was a nurse. Everywhere else it's us. And then I just follow this. I don't know. From what I hear, this seems to work out okay. Sometimes the attending might override it and be like, give a couple extra units. But I think there's definitely a cultural difference. From the nursing side versus like the MD medical school, and then especially side, and particularly anesthesia, because we do more things that nurses do, like push meds, set up tubing, do stuff. Like we do hands-on stuff more than internal medicine doctors. Like, there's my white coat. Why don't you do this? And we're just very kind of relaxed, laissez-faire about things. Like we don't know about any interactions in the tubing. All things go through one IV in the OR, except for like maybe 2 things. Like, and it's different because like the rates are fast. It's not going to build up. Like it is a different thing. We use stopcocks. We push things fast. We can monitor closely. We're used to that, and it's safer most of the time because we are one-to-one monitoring really closely, getting like Q2-minute vitals for hours on end. We have time that we like. I think the experience is I can make the blood pressure any number I want. I can make the heart rate any number I want. I can make that glucose go up, down, like all the things, all the numbers. We can kind of make it whatever we want, usually pretty easily. We're constantly moving like oxygen up and down, CO2 up and down. Like so, it's very different to like have someone else be doing things, having things take time, having to like set someone up to succeed, with only like a 2-hour time frame to then kind of set them off. Anyway, does that make sense? Like that's kind of how we think. I think is, and it's different it's a very different philosophy and kind of experience and comfort level. And it's very shocking and jarring to suddenly have to think, oh, longer term, I can't always rescue this if we give a little extra Livedolol. Like, I can't just sit there pushing fennel for an hour with 30 other patients. So I think sometimes that's maybe a point of contention or a good thing to point out, like, hey, that might be a little too aggressive. Like, just realize that's what we're used to. And we're not meaning to like cause a huge issue by getting everyone on a fennel drip after like 50 Livedolol. So yeah, this is again experience, kind of collaboration, helping us out. Yeah, we've been doing this like a year or whatever. Like, you've been doing this probably much longer for any of you. So, yeah, that could run good stuff. Okay, kidney stuff, potassium. I think all these numbers, especially potassium, is tricky because everyone will tell you something different. And I've asked multiple attendings, they all have different thoughts. Every patient's different. Every patient has different situations. Sometimes they have CKD, ESRD, their potassium's always 6 to 6.5 every day. They've never checked it and they're fine. And they go up to 7 or 8 and you do all the things and you check things and they're fine. Someone else is normally like 3.5 and they go to like 5.8 and suddenly you're like freaking out and things are bad. So the number doesn't always mean a lot. But when do you all get scared in general? Like, what are your experiences with this? Like, do you have heart thresholds where you're like, damn, like we need to like do something versus like, sure.
I think down here, like working more and more with anesthesia, like over the years, you find that we are a little more laissez-faire, or to use your word,
Sure.
or relaxed, like not as aggressive to like jump on it. Whereas in the ER where I came from, yeah, I would have treated that right then and there, like boom, boom, boom.
Interesting.
So
Yeah.
I think that it comes to experience. Looking at the whole picture, like, do we need to be aggressive or not right now in the immediate recovery of this patient?
Yeah.
Or is
Sure.
it something that we can pass along to the ICU or floor and they have to monitor, treat?
Yeah.
No. Continue to-
That's fair.
I think we might all cringe a little bit. It
Yeah.
takes a little bit of time.
It does take
Yeah.
time.
Lots of stuff.
Yeah.
It's a lot, like gathering a lot of stuff.
Yeah, I hear you. And that's helpful too, to like be just straight up like, hey, this is a lot, can it be done in the ICU?
Treat it.
That's helpful to tell us, be like, just, that's fine, it's totally fine just to kind of subject, because like we don't always know too how difficult it is to get things here. Certain things are like really easy for us to just grab, they're just there and we just do it, and versus we need to, it's a different setup for y'all, different workflow. And also the monitoring time frame we don't know about. So this is super helpful to be constantly telling us, hey, are you sure you want to do that kind of thing? They've already been here 4 hours. Like, they have a great ICU bed already ready versus we're on hold. We're gonna be here 2 hours anyway. We have some time. Like, that's really helpful to know. Especially when it's like 3 o'clock and we have 30 people here and I'm like running around and I don't even know anybody by that point. It's just like putting out fires kind of thing. And it's difficult to always do the thorough chart review that I'd want to do. Just because of the way the workflow and staffing works, which is what it is. But yeah, I guess it's probably good to just think about potassium when it hits 6. 6 is big. In this presentation, 6s are just evil. Like, just give me a heads up, like, hey, you know, the potassium's 6 and it was 4 before, or hey, it's 6 and it's always been 6. And it's like, okay. Or if you're like potassium 6.5, we might want to be everyone just getting ready to give them insulin, probably, unless there's some crazy circumstance where they've always been 7, but probably 6.5. I'd be pretty alarmed grabbing the things. What are the things we want to do to treat this? Say it's 7, what are we gonna do? And it normally is 5. I heard insulin and D50, calcium gluconate. Anything else we want to do? D50 with the insulin, love that. Calcium. Dialyze, yeah.
I just had this patient last week.
Yeah, yeah.
And we actually ended up in, of all the treatment we did, he was late going to 2 MRIs. So when he was in MRI, they told me, hey, we're going to cancel. You're too late to come in. I'm like, well, we got to treat this patient. You know what I mean? Like, so we're supposed to be dialyzed that day. So why didn't they just dialyze before they came in and we are treating the patient? So it's frustrating that we try our best, you know, to treat the patients and we just cancel.
Mhm.
So
Yeah.
I know it's hard for the patients.
Oh, yeah. Definitely frustrating. How much time do we have?
We got like 5.
Okay. Yeah, so I guess if you start having EKG changes, that's helpful to know just because that means it's severe enough that the body's not used to that level of potassium. So that's why we often will get the EKG, just check where we're at, regardless of whether we're going to treat or not. Some people are like, yeah, it's too high, I'm going to treat it regardless. But that EKG is useful. Of note, like the T waves start to get kind of narrow and tall on these tellies. It sometimes will fool you, I feel like is my experience, where they look tall and they're not, or vice versa. So it's hard to go off of that. Also, you might lose your P waves. They get flattened out. So I mean, you might think you're in kind of AFib or something else, but it's just the potassium dropping those P waves. So just that's a good caveat. We have a whole algorithm. We have an order set. I think the big things are like 1 to 2 calcium. You can push it pretty fast. Like it will raise your pressure, and you don't want to like do it just the whole stick at once, but that can be given pretty aggressively. And in the OR, we do that all the time, but I would want to get that in. I've noted it's not going to change your EKG. It's not going to affect your potassium. How long does it last for? It's beneficial protective effect. Like 30 minutes. So you should redose that. If they're here a long time, we need to redose calcium if it's like a potassium bait. So be thinking that, because we might lose track, but like remember, like, hey, this lasts 30 to maybe 60 minutes. Maybe if you give 2 grams, it might last a little longer. So 1 might not be enough. Usually you can get a lot of calcium. It's okay to get more. So we should be getting that in. Plus minus EKG. Insulin's IV, not sub-Q. So if we order that wrong, please let us know. The order set now is IV, so that'll take effect quicker. And how long does that last for? I didn't hear it. Sorry. Well, I mean, it depends if it's a drip or just a push. It's usually just a push. It only lasts a few hours. So by the time they go to the ICU, they might need a redose if they've been here a while. So just realize this is not an all-day thing. You need to redose these things. And it might take like 20, 30 minutes to like really kick in. So you could still have a cardiac arrest, even though you're like, whew, insulin's in. And it could still be going up, and you could still have an issue in that window. You might need more than 1 D50 amp. Dosing, the default order set is 5 units. If it's really high potassium, that might be enough. That might not be enough. We as juniors are not super experienced with insulin dosing. If you see a really high K, like over 6.5, tell us, hey, you might want 10 units, 10 units, 4.1 units per kg up to 10. Like 5 may not be enough. So, and we can always give more D50. We want that K to come down. So let's, yeah, do the thing. Bicarb, some people do. You don't really need it unless they're acidotic. Lasix is another option. Hemodialysis is effective. CRT is not as good. So HD is kind of where you want to go if it's really not working. Albuterol is in the order set. You need technically, I think, like 10 milligrams, more than those 2.5s. You need a lot of albuterol. You're probably going to get tachycardia. It may not be safe for some people. And it probably is not very effective. So a lot of people just don't even bother with albuterol. And again, yeah, these things only last a few hours. These are all just temporizing measures until you get dialysis, pee it out, Lasix, whatever. Surgeons can cause issues like this. You don't want a bloodbath. If you do, oh, this is a really important one, actually. If you lose half your blood volume, like I just spill half my blood on the floor like paint, what's the hemoglobin change? If it's half your blood volume, let's say I started at 12. Yeah, so we drew a gas. Hemoglobin was 12. I lose half my blood volume. 2 minutes later, we draw another gas. It's going to be 6. It'll be 12. This is a super important principle for transfusion. Yes. Yes. So you have to be giving them fluid to see the change. So if they're under resuscitated, their lactate's 5, they've only gotten 1 liter for 3 liters EBL. They just came out of the OR. The hemoglobin's going to still be high, but they might start getting hypotensive with a high hemoglobin. You're like, they need more fluid. If there's a lot of EBL, they might need blood. That's why transfusion thresholds are really weird if you haven't fully resuscitated the patient. In general, 7 is a pretty sharp cutoff most people transfuse. 8 if they have cardiac history, but if they're hypotensive, they've gotten a ton of fluid, they had a lot of bleeding, you might need blood instead of fluid. So if we're ordering another liter, like, hey, just try a liter, and you're like, hey, they're getting like systolics 80s, maybe blood. Like, tell us, hey, maybe blood. Like, that's a useful prompting for us to think like, hey, we haven't resuscitated enough. So but getting a gas, checking lactate is good. And oh, this is another thing that came up that I just wanted to point out. I've had a few patients here since I've been here, and I'm new to all this, but they had like 9 or 10 out of 10 pain, and we stopped giving opioids because of a heart rate of like 50, and they came in with a heart rate of like 50 or 60. A little bit of fentanyl or morphine or whatever is probably, at least in my experience, doesn't drop the heart rate that much. It will drop it if you're like 90s heart rate and they're in tons of pain, and you take away the pain, that sympathetic tone drops and the heart rate will drop. That's expected, that's okay. But if you're already kind of bradycardic because of a beta blocker, you may not get that much of a decrease. Or if you do decrease or worried about it, that's fine. I will give glycopyrrolate. It will go up. If that's contraindicated for some reason, or if they're going home, we're not feeling good about that, that's fine. Let's have the conversation. But like, please just let the PACU resident know that you're worried about the bradycardia, and you don't want to give them opioids, and we can talk about it. And maybe we could treat it, maybe we could figure something out. But please like, just let us know if you're worried about it. Like, I mean, I do so many notes and clicking, like I'd love to treat pain if I can. That's like why I went in my field. So just let's have a conversation. Any other thoughts or concerns about that? Maybe I'm missing something with that, because again, I'm new to a lot of this. And I'm used to the OR where I just give all kinds of things to play with the heart rate. But,
To me, I never worry about the heart rate.
that's good. What do you mean?
They're different, they're pulse ox, and they're still saying, oh, and what's the famous thing? I said, I can't give you any, you're not breathing good.
That's a good point.
So I never worry about it.
That's a good point. Yeah, I like that. Yeah, kind of dose until they start desatting. Yeah, I think that's reasonable. I that's something I'm less experienced about, because I'm used to like dosing opioid till they stop breathing and I put a tube in. So that's something, it's an open question for me, but that seems reasonable though. Yeah, any other thoughts? I think we're getting close to being overtime-ish, or if not already. So thank you for,
As our crowd is gonna start this.
yeah.
But if you had more, I mean, I'm still recording.
I think at the end, yeah, that's it.
Okay.
Yeah, we can be a little going ahead at times, but we've come a long way, you know, we've come a long way. Yeah, so and then again, I'll just apologize for all the jerk residents, or if I'm really stressed and like getting flooded and then dismissive, or with my mask you can't see them actually smiling or look like I'm frowning. Yeah, I feel like there's so much miscommunication between residents and nursing, and misunderstanding and frustration on both sides, and it's just, I don't know how to fix it. I think it's really sad. It's a huge part of my job dissatisfaction, is all the like passive aggressiveness and like frustrations and miscommunications, when most of the time most of us are like kind of nice people, and we all kind of went into this to help people, and we get jaded at times, but it's just, yeah, I don't know. I don't know how to fix it. I wish there was more that would be done, could be done. I'm not great about it. I would love to like say hi to all you and introduce myself and chat about our kids, but like I need to study for my test in a couple of weeks. So I'm going to take my downtime to be studying and not hanging out and chatting. Like there's also these things, right, where it's like, it makes it look like I'm not paying attention, or I don't care, or I'm not nice or whatever. And there's times that I'm not nice, but it's hard, you know. I guess I would just try to give each other the benefit of the doubt and be open and being like, oh, maybe they're having a bad day, or oh, like maybe they're busy or stressed or whatever. Like, I don't know. It's been a hard few years for everyone.
I think the hardest thing for us is when there's not an anesthesiologist in the unit.
Okay.
When you guys take off and we need you, it's like, oh my God, where are they? You know?
Yeah.
And it would be nice to like two of you at a time, get spoiled with